Well, how's everyone doing today? No, it's a lot of information, but I appreciate everyone bearing with us. We all had a great time last night at dinner and karaoke and some dancing at the end. So how many here, is this your first time at camp? Just raise your hand. Wow, really? Wow, that's incredible. So welcome. I know this, and I can imagine this is a lot of information to digest, and I'm sure you're coming with a lot of questions. And so I hope that you leave these sessions in camp overall with more information and empowered to really go back home and feel confident in the plan that you have. So I wanted to spend a little bit of time talking about how I am approaching our adult patient population with telomere biology disorders. And so just by way of context, I'm an adult trained hematologist-oncologist. I grew up in Florida. I did my medicine training at the University of Pennsylvania in Philadelphia, and then I did my fellowship training in Boston at Dana-Farber. I learned a lot from this gentleman in the back. Dr. Paul Lindsley is going to be speaking next. He trained me in all things blood related, and really was the inspiration for us to really start to think about how can we develop a multidisciplinary program for our adult patients. And so that's what I'll share with you today. And so this really started 4 years ago. I was still finishing up my training. I wasn't a fully fledged hematologist-oncologist yet. But what we recognized from our clinical care of patients, as well as the research that we were doing in the lab, was that as adult providers, we are sadly underdiagnosing telomere biology disorders dramatically. It's not just a small amount, it's a large number of patients that in our current system and approaches that we take for diagnosis, we are failing to recognize patients and families impacted by these conditions. And so this was a primary motivation to develop this program to really accomplish several goals. One is to enhance the way that we're diagnosing patients and making sure that we're not missing those cases. But even once a diagnosis is made, how do we integrate care? How do we think about patients and their needs holistically? Because I'm sure many of you in this room have experienced this, where you go to a provider, they understand their area of expertise very well, but as a patient, they may have other issues that need to be addressed, and the lack of coordination and cohesion between subspecialties is something that I hear very frequently on the adult side. This is exactly why we wanted to develop this program. So this is our clinical team here. I don't know why it's so blurry, but I'm right there. You can't tell. Dr. Lindsley's right there. You just heard from Dr. Agarwal, who's been really instrumental in guiding us as we started to develop this program. Dr. Benjamin Reilly, who's not here with us, but pediatric and adult trained pulmonary geneticist, has been really instrumental in evaluating our patients at risk of lung disease and who have lung disease. We have other members of the team. You heard about the amazing work that Will Manhurst has done on the nucleotide metabolism side of things. We also have Dr. Fred Tsai in our lab, who's really deeply investigating the blood changes that I'll talk a little bit about in terms of the changes that occur in blood cells in patients with telomere biology disorders and how that impacts other manifestations, including risk of blood cancer. So I'll talk a little bit about that. We also have a senior staff scientist in our program, which has really been a critical addition to our team. And so Andrew Bierke, Dr. Bierke is really pioneering a lot of the efforts in the lab to really ask the important questions that are going to be impactful for the way we care for our patients. And so what I'm showing you here is just the outline of our program. So over the last 4 years, we've really grown rapidly. When I first started this program, many on the adult side felt like there's going to be a handful of patients for you to see. It'll be a nice area to develop. We really hadn't any idea how many patients we would ultimately be able to serve. And I wanted to highlight the various ways in which patients are coming to us. And so what I'm showing you here, I apologize for it being blurry, but there's a programmatic core that it starts with us on the adult side and the hematology group. And so we see a lot of patients that come to our doors that ultimately end up having a telomere biology disorder that if we just use our eyes and clinical history taking, we would otherwise miss them. And this was key insights from the work that we did when I was training, where we realized that actually we just need to sequence everyone that comes into our door to really understand fully, do they have a telomere biology disorder or not? And so one of the changes that we made over the last several years is now everyone that walks into the door of Dana-Farber that has a known or suspected blood disorder, we are sequencing several of the telomere-associated genes to systematically evaluate this, recognizing that our own ability to just look at patients is very limited to detect all cases of TBD. And so we see a lot of patients like that. We have close collaborations with our stem cell transplant colleagues, because as Dr. Agarwal and Dr. Olson have already alluded to, is that patients that do require the assistance of a stem cell transplant really have to have a careful consideration of the types of approaches that we take to really optimize outcomes for our patients. Another thing that I really want to highlight for this group in particular is our close connection with Boston Children's and the pediatric experts there. And so many of the patients that come to our program are initially diagnosed as kids with telomere biology disorders. They develop years of trust with their care team, and then at some point they grow up. They turn 18, 21, 25, 30. At some point, they come to the adult side. And I have talked to many of you here, many also in Boston, that have expressed to me how distressing and anxiety provoking it is when we talk about transitions of care from the pediatric side to the adult teams. And I just wanted to highlight that the way that we're approaching this in our program is really intended to limit that as much as possible. And so I can just tell you what we do in our program. So we work very closely with Dr. Agarwal. And so if there's a patient that's coming to us, transitioning from the pediatric side to the adult side, we sit down and we talk about it. We really go in depth in terms of what their medical history is, what problems they've had, what our approach should be moving forward, and really identifying prior to them actually coming to the adult side, what are the team members that we need to have in place already? Who do they need to be integrated with on the adult side at the first possible instance? And so the other piece of this I wanted to mention is that Dana-Farber is a cancer hospital. And so patients come to Dana-Farber because they've had a diagnosis of cancer or they have a strong family history of cancer. And through this, a lot of our patients are seen in our genetics group and undergo genetic testing for mostly hereditary cancer, but it also includes other genes. And through the history taken, we often find that patients and families are impacted by telomere biology disorders, but are unknown. And so we do sequencing in that way and also find additional patients. And so over this time, we have now over 160 patients. And as you can see by the average age, many of them are older adults. The average age of our patient population is 58, with a range of the early 20s to late 70s. And so really, as it was already mentioned today, the conditions that are associated with telomere biology disorders really can impact people across the age spectrum. And one other point I'll make on the program at large is that we're able through this mechanism to provide comprehensive care to multiple generations family. And so Dr. Agarwal and I have shared several families in which we have 2 or even 3 generations of the family where we can actually have integration of the care. And I think that's a real strength of these kinds of centers of excellence that Team Telomere has been instrumental in delivering. Just also highlighting here the number of clinical subspecialties that we have in our program. I wanted to also make a few comments about how we're diagnosing or unfortunately missing the diagnosis in patients, adult patients with telomere biology disorders. So many of you have seen plots like this before. This is a repeat diagnostics plot of a patient that has clearly very short telomeres. And so this is one of the patients in our program. And one of the challenges that I found on the adult side is that many of the adult providers, one, don't know to send the test. And if they do send this test, they don't understand how to interpret it properly. And I think that's a really important point. And one of the things I'll mention too is that on the pediatric side, it's often the case that the telomeres are less than the first percentile. That's a very, very specific finding in pediatric patients. What we find on the adult side, particularly as our patients are in their 60s and 70s, is that it gets really challenging to really rely on that first percentile for age. And so what I wanted to show you is that when we look at our patients with clinically confirmed telomere biology disorders based on strong family history, based on personal history, some of which have multiple organ systems involved, not all of these patients have telomere lengths less than the first percentile. And this is a point I have to make consistently to our adult colleagues in pulmonology and hepatology to really understand that this biology is difficult to kind of use a single cutoff. And so you really have to integrate the telomere testing with some of the history for patients, as well as the genetic testing that I'll talk about as well. And so I just really want to highlight, because our adults, I know others have already talked about this, so I won't belabor it too much, but we know that there are over 15 to 17 now known genes implicated in telomere biology disorders. And the variants that occur in these are of various types. Sometimes it's quite obvious to know that a given change is going to disrupt the way a given gene functions. And a lot of the times, though, it's really difficult to know if we find a genetic variant in the gene, is this meaningful? Is this something that's going to be causal of a disease or a risk factor for disease? And so I'm sure many of you may have heard the phrase variants of uncertain significance. I'm seeing a lot of nods. Yeah. So I mean, most of the tests that we order from a genetic standpoint, most of them come back with one or more variants of uncertain significance. And one of the key things I wanted to highlight in this group is that we are really taking this head on in terms of how we're addressing this in our program. And so one of the more common genes that is altered in patients with telomere biology disorders, particularly in adults, is the gene TERT, shown here, the telomerase gene. And so as a first step towards this, we've developed an assay in our lab where we can actually put an individual variance in a system that we know and understand well and express it to see how does it work? How well does it work relative to the copy of telomerase that most people have? And this has been a very helpful tool in us to resolve this category of variances of uncertain significance. Because I talked to several of you yesterday who've had these kinds of results come back, and it can be a real challenge for patients, for families, and providers to really understand what is the clinical action that can be taken when we get these results. And really understanding risk in families is really critical to understand what are the variants and what we know about them. And so I also want to highlight too, that when we do genetic testing for our patients, it's really critical that it's comprehensive. What do I mean? So one of the things that we see consistently on the adult side is that they may send 6 genes, they may send 7 genes, 8 genes. But one of the things that I'm seeing consistently is that we really need to be comprehensive with the genetic screening that we do for our patients, because many of the gene panels that are currently available are not updated with the new knowledge of all the genes that are important to look for. So I just want to highlight. When we look across big groups of TBD patients, so what I'm showing here is the NIH cohort on the left and our program cohort, Dana-Farber on the right. And what you can see is that among the patients that are identified, the vast majority of these patients have variants in key genes like TERT, the ARTEL1 gene, as well as TERT and PARM. And then in cohorts where there's more representation of younger patients, we see a slightly different spectrum of mutations in genes like CTC1, RAPTD3, ACD, and NTBC1. And so on the adult side, the majority of the cases that we see are of the type of autosomal dominant. And what does that mean? That means that we all have 2 copies of a given gene, one from mom and one from dad. And for an autosomal dominant type of condition, it means that we only need 1 copy that's abnormal to be at risk of getting a given condition. And so the majority of the patients that I see on the adult side have that path. They have a single abnormal copy of a given gene, and that is what's putting them and others in the family at risk of mentioned. And so we've already talked about the wide spectrum of clinical manifestations of telomere biology disorders. And this is important to keep in mind. And this is, I think, is also getting to the point that I made earlier, which is that the diagnosis, particularly in adults, can be quite challenging. Why is that? One reason is that when we are, as doctors, are trained, we're trained to recognize patterns, easily recognizable kind of knee-jerk patterns. This test, this value, with this history equals this. And it's really difficult, and actually I would argue really improper to apply that logic to trying to diagnose patients with telomere biology disorders that we now know, and we've heard today, can manifest in a myriad of ways. And the other thing that I will highlight here is that in particularly in adult patients, the symptomatology can be very subtle. And this is getting to the point that I made about sometimes our clinical ascertainment of symptoms and likelihood of TBD is really, really imperfect. And this is why, again, I'm emphasizing genetic testing and the low threshold of telomere testing in our patients. I'm highlighting here as well that the age of onset of some of these conditions that we've been talking about does vary. And so in general, what I'm showing here is that the majority of the patients that come to our program have some degree of bone marrow failure. Many of them do have some liver dysfunction, and a large proportion of these patients that come to see us have some degree of interstitial lung disease, some scarring in the lungs. And so I want to talk about, and Dr. Savage did an excellent job explaining the physiology of the lungs, the ways in which it can go awry when there's excess scar tissue. And so what I wanted to highlight here is what our program experience has been. And so the majority of our patients actually in our adult patient population have some degree of interstitial lung disease. And this is variable. And what I'm showing you here on the right is an image from a paper several years ago, which really had one single message, which is that the patterns of lung disease in patients with telomere biology disorders are variable. meaning that you can't use a single pattern of lung disease to know whether one patient has or does not have a telomere disorder. This is surprisingly something that I've had to bring up many times to providers, even pulmonologists, who have been trained to recognize usual interstitial pneumonia or idiopathic pulmonary fibrosis as the single type of lung disease that can be associated with Telomere biology disorders. But the reality is it's not that simple. And so I'm showing you this just to highlight this, is that this was several images. These were CT images on the top here, showing different patterns of scarring, different patterns of inflammation that radiologists and pulmonologists recognize as distinct entities. But these are all occurring in patients with a unifying biology. They're all patients with short telomeres. And this is actually true within families. And so there can be multiple people in families that are impacted by this with lung disease. But when we look at images and we look at the biopsy tissues, they can look very different. And I think this is something that is really important to keep in mind. The other thing I have to mention as well is that so many people on the adult side are misdiagnosed because of a reported diagnosis of COPD or lung disease attributed to smoking, even though they may have smoked very minimally in college for a short period of time. And so I also want to highlight that it's really critical for patients and families, if they have symptoms, to really have a comprehensive evaluation and to not assume, not make assumptions that someone may have a more typical sporadic form of lung disease. I'm highlighting here on the slide is that many of these patients, as mentioned by Dr. Savage, are on antifibrotic agents. And so we do, our pulmonary colleagues really are prescribing these for the majority of these patients. And what we're doing in our program specifically is that as patients are diagnosed with interstitial lung disease and are being evaluated by our lung transplant group, they want us to do a comprehensive blood evaluation. And so what we've done in our program is that every patient that's being seen for a potential lung transplant comes to our group for a bone marrow evaluation, comprehensive blood monitoring. And as I'll mention in a few slides, looking at the presence or absence of blood mutations that may influence the risk down the line in the future of blood complications. And so a little bit more about the bone marrow. So Dr. Olson did a great job highlighting the spectrum of blood phenotypes that we can see and do see in patients with telomere biology disorders. I think the most important thing, not the most important, but the first thing I'll say about this is that hypocellular bone marrow is not a disease unto itself. So many patients with telomere disorders have hypocellular marrow, and I think Dr. Olson underscored this perfectly, is that as long as the bone marrow function is okay, as long as the blood counts are being maintained in the proper range or close to it, the hypocellular marrow in and of itself is not, I don't get nervous about that, per se. One of the other features that we can also see, but it's not necessarily a worrisome finding in and of itself, is that sometimes the red blood cells are bigger than average. And so we call that macrocytosis. And the value that you'll see on your blood work that corresponds to that is this MCV abbreviation. And so we can see individuals that have an elevated MCV their whole life, and it never changes. And if there's no other findings or changes on the blood work, I'm very reassured by that. What does it represent? I think it represents that the bone marrow is trying a little harder to keep up with the production of healthy red blood cells, but it's not a disease until it's. We start to get a little bit more thoughtful about how we monitor patients when we start to see that blood counts are actually low. They're actually outside of the normal range. And so when we see the white blood cells, and particularly the neutrophils, starting to drift down, or if patients are now newly anemic when they walk before, or if their platelets are low, these are situations where now, yes, we do want to take a look into the bone marrow. We want to understand all of the aspects of bone marrow function, including looking at the mutations, which I'll talk about. What I'm showing here on the right is really the spectrum of cellularity that we can see in the bone marrow. And so very young children, when we're all born, if we're healthy, all of our blood cell or space in the bone marrow is full of healthy blood forming cells. And that naturally goes down with time. That's what it is to be human. And so if you are lucky enough to make it to 100 and someone, for some reason, wanted to do a bone marrow biopsy, most of your bone marrow is going to be fat at that point. And it goes down predictably with age. And so, like I said before, many of the patients with telomere disorders will have some degree of hypocellularity, but we really have to take into consideration all of the other factors. There is undoubtedly an increased risk in patients with telomere biology disorders are developing blood cancers. And this includes myelodysplastic syndrome, which is tends to be more of a chronic condition, but can get worse over time into something more aggressive like acute. And so one of the things that is a passion of my ANL program is to really understand at the most fundamental level, what are the changes that are occurring in blood cells in patients with TBD that are either increasing or decreasing one's risk of developing these complications of blood cancers. And so we're starting to get more information on that now. Dr. Olson talked about this term, and I just want to make sure we're all on the same page. Clonal hematopoiesis, what does that really mean? It just means mutations in the blood that are acquired. These are not the same types of DNA changes that we think about when we're testing patients for diagnosing a telomere disorder, because those changes are in all of our cells, and their skin, and our liver, everywhere. These, what we're talking about here, are acquired changes that happen sometime in our lifetime. And actually, everyone sitting here today has some of these changes. All of us, healthy or otherwise, we all have these changes. Not only in our blood, in our skin, and our liver, we constantly are acquiring DNA changes as we have every day of our life. What's notable though is that when we look at the types of changes that happen in the blood of patients with telomere biology disorders, we are starting through multiple studies now seeing a predictable pattern. And so what I'm showing you here is a distillation of work done by our group, done by the NIH group, as well as Penn, which has really shown some key findings that the types of changes that we see in blood cells are of a certain type. And we see a certain number of gene mutations, and some of these have apparently a higher risk of developing into those complications that I mentioned in the DSM. We actually have an ongoing study through the CCCTAA. I'm leading the clonal hematopoiesis aspect. Emma Boak is leading the study looking at outcomes in patients with MDS and acute leukemia and telomere biology disorders. And the goal here is really to learn from increased numbers. And so we're pulling samples and data from over 2,000 different institutions currently to really try to understand what are the changes in the blood of patients with telomere biology that really matter. And among patients that actually unfortunately develop a blood cancer like MDS or AML, how can we actually be treating those patients? What is the optimal treatment approach? So we're starting to begin to ask those questions. I'll also mention that at Dana-Farber, we are a high volume stem cell transplant center. We do about 300 allogeneic stem cell transplants per year. This includes, easily a dozen or so telomere biology disorder patients every year as well. And so with that experience, we have a long track record of understanding the factors that are important. But I'll also highlight that, as Dr. Agarwal has pioneered, we know that patients with TBD require specialized considerations for stem cell transplant. And so we really have to be really thoughtful. And so what I would tell this group is that if you or someone finds themselves in a situation where they may need an evaluation for stem cell transplant, I think it's really critical to seek out expertise of patients, of providers that have done stem cell transplants for patients specifically with telomere biology disorders, because it is a very nuanced approach that has to be considered. It hasn't been mentioned yet, so I'll just briefly mention the liver. I think it's definitely worth talking about, particularly on the adult side. One of the things that we've been doing systematically in our program is screening for even subclinical liver disease that would not be evident by blood work, that would not be evident by symptoms. And so there's different ways that we can do this. The standard test that we typically send as a screening tool is a liver fibroscan. It's a special test that looks at the stiffness of the liver. And so in patients that have more scar tissue that's developed, we can actually start to see that reflected in the numbers that we get from this test. And so the changes that we can see in the liver in patients with telomere biology disorders are also varied. It's very just like we see in the lungs. And so the most common thing that I see in our patients is that there can be increased fatty content in the liver in patients with food. And this can progress over time without proper treatment or monitoring to where there's more scar tissue. And ultimately, unfortunately, some of these patients do develop more advanced disease like liver cirrhosis. And these are the patients that we start to think about whether or not an organ transplant is the right approach. I also want to highlight the drug-induced liver injury here. One of the things that I think is important to recognize is that even in patients that don't have overt liver fibrosis or cirrhosis, we do see that their liver seems to be more sensitive to some medications. And so sometimes it's important to recognize that medications that we wouldn't expect to be an issue can be at sometimes, in some cases, in patients with TBD, and that just may have to be factored in. In terms of screening that we talked about, liver function test and imaging, we certainly don't routinely do liver biopsy, but if there's a question about whether or not someone has a certain type of liver disease, sometimes we do think about doing liver biopsy. These organ systems are all connected too, and I think Dr. Savage touched on this already. So the liver and the lungs, there's a clear connection there, right? And so patients can have advanced liver disease and have issues related to requiring oxygen, issues related to breathing. And so hepatopulmonary syndrome is a known issue that can arise in patients with telomere biology disorders. And so there's additional studies that we can order for our patients to better assess that as well. How do I talk to my patients about liver disease? I certainly advise them to minimize the consumption of alcohol, things that would otherwise be a little bit damaging to the liver. Maintaining a healthy weight is critical because we know that BMI is closely related with how healthy the liver is and how much fat content is in the liver. I put up here a provocative kind of thought-provoking statement is that we are starting to get new medications on board for different indications for either weight loss or better glucose control that also have some beneficial effects on the way the liver handles fat. We have very limited, if any, data other than anecdotes in patients with telomere biology disorders. But one of the things that we're thinking about programmatically is what are the potential options for designing clinical trials in the future in which we could actually study pharmacologic interventions that might help the liver disease in patients with TBD or prevent liver disease from happening. So these are questions on the research side that we're thinking about. And certainly in our program, we do have several patients that have undergone liver transplantation. And I think that's just something that we hope to avoid in our patients, but obviously monitoring is really critical. The last organ system that I'll talk about just briefly is bone health. And so adults with TBD actually are at much higher risk than the average person of having decreased bone mineral density. And so this doesn't get talked about quite as much as I think it should. And some of this is just, I've been doing this now for 4 years. It's becoming more evident that this is really something we need to focus on. There's actually a study, I want to highlight this at the bottom. So through the CCCTAA, this INSIGHT study is actively ongoing. The data has been pulled. This is another multi-center study. Hundreds of patients, I think 400 to 500 patients have been accumulated here to really understand the outcomes and the prevalence of osteopenia, osteoporosis, avascular necrosis, which is another problem that can arise in the bones of patients with TBD. And so I think this is something that is important also when we think about those patients of ours that might need transplant, because we know that transplantation is also another insult to the bone health overall, and that the density can continue to decline. So this is also something I don't want providers, wherever they may be, to neglect, is that really the bone health is something we should be focused on. And this is a ton of information. My goodness, it's a ton of information, a lot of things to consider. You're not going to memorize it. You're not going to digest it all, nor should you try. So we do have it all distilled into the clinical care guidelines here. And so for anyone that isn't familiar with it, this is available online. Team Telomere can also provide a hard copy for you to take home with you or to be shipped to your house. And if reading a big textbook is too much, which I don't blame you, there are much more abbreviated one-page resources that really go over these key points for each organ system. And so there's an ongoing present research support. So with that, I'll end and say that, I think it's clear to me and hope to you as well that adult patients with TBD really require a multidisciplinary and a personalized approach at that. I really recommend, if possible, to really seek out guidance from a center of excellence. And so we now have many centers of excellence in the Team Telomere network, and I think in the future they're only going to continue to have more. And I really think it's valuable for patients, particularly newly diagnosed, to at least have an expert kind of weigh in and evaluate them at least once, to provide, if nothing else, a blueprint and a template for other providers that may come across their case and really understand without having to go into a textbook or Google or ChatGPT to really say, this is what they have and I understand it. And again, I can't say it enough. Team Telomere is an invaluable resource, and I just really want to thank everyone for your attention, and I hope you all have a great rest of the camp. Happy to take questions.